All right, everybody, we're going to get started. We do have a case and a didactic today, so we'll start with the case. Margie, if you're okay with that, and then we'll move into the didactic. Let's
Okay.
start with some introductions real quick. Margie, do you want to start?
Oh, yeah, I'm Margie O'Kelly. I am a behavioral health provider, and I work at the school-based health centers in the River area in Kanawha County.
Awesome, thank you. Okay, and Alicia? Alicia, you are muted. Oh, I can see you.
Oh no.
Okay. Alicia, if there's an up arrow next to that mute button over in the corner, it might have different options for you to pick.
How about now? Okay. I'm Alicia Maddox. I'm a pediatrician at Cardinal Pediatrics in Bridgeport, West Virginia.
Awesome, thank you. Happy to have you join today.
Thank you.
Hey, Dr. Todd.
Yes.
You came out. You're still on the screen.
I'm still on the screen.
Yeah.
Okay, let's see. Dr. Todd and Hava.
Hi. We're having some technical difficulties. Hava Urecki and Dr. Ta from Clendenin.
Awesome. Thank you both. Okay. Jen, are you there, Jen? I know you'll be back. Okay, we'll wait on the phone number in 2200. All right. If anybody's having problems introducing themselves, you're welcome to use the chat and just tell us who you are and where you're from. So here. Yeah.
I'm Amanda Newhouse. I am social work faculty here at WVU Medicine.
I'm Caitlin Ettinger, the West coordinator.
I'm Tanya Goodikins. I'm a child and adolescent psychiatrist here at WVU.
I'm Camille Shawi. I'm the pilot grant coordinator for CTSI.
Awesome. So, Mark, if you're okay, I'm going to share your case.
Okay. The case that I kind of picked for today is a 9-year-old male. He was referred to behavioral health services by a school nurse about 2 years ago due to anger and irritability. He has been seen by our pediatricians in the community health center since 2013, but there wasn't a lot of report about behavioral issues and that kind of thing in his earlier history. On his problem list currently is listed obesity as well as poor dental care. He's not taking any medicines at this time. In his early history, he did have a lot of ear infections, had a like articulation problems, speech problems, and a leg length discrepancy. So when he first came to see me, as I said, he was referred by the school nurse in 2017 due to anger. He was first seen in the community health center, so mom brought him to me at the community health center. But after his initial visit, he often failed to keep his appointments there. I was able to start seeing him more regularly in the school-based health center in 2018 because I went to the elementary school at that point. And he was seen either weekly or every other week for the remainder of the school year. And I last saw him in May. I offered to have mom bring him in for appointments over the summer, and she has not scheduled any appointments since May. So when I initially saw him, he acknowledged that he had anger frequently, and he said that it was directed towards his peers because his peers bully him. He kind of described that he loses control when he gets angry and says that he flips out, he yells at people, he will get physical. will sometimes hit, throw punches, those types of things. He told me at that intake that he likes being the angry guy because mess with him when he's the angry guy, and they can't hurt him when he's the angry guy. But he does say that he regrets his behavior later at times, mostly when he gets into trouble. He told me that he has anger outbursts 5 days a week, and that it primarily occurs at school. He also said that he gets angry at home when mom asks him to comply with certain rules at home. And he also reported getting angry when he couldn't get his father's attention. He, at that point, had been sent to the principal's office several times. He'd never been suspended. He said that he'd gotten into 6 fights at school. He reported with his mood, he said that he was never as happy as he should be. And he said that he doesn't smile at school. Mom also described mood as irritable. And she said that he either gets his way or he pouts. He said that there was nothing that he enjoys doing, nothing that's fun for him. He and mom both said that he has trouble falling asleep at night. Mom said at that point that he was sleeping like 6 or 7 hours, and that he woke up irritable and like angry at the world. He said that he feels tired a lot at school. There were no changes in appetite at that point. He did say that he has trouble paying attention and falls asleep in class, and that's something that they had reported to me at school too, that he will just put his head down and fall asleep at school. He likes to like pull his hoodie over his head, and kind of got into trouble a lot for that in the last school year. He was really critical of himself and other people. He also kind of had these vague thoughts of, I wish I wasn't here. He said that he had thoughts about eating a foam plate because he thought it would kill him. But he didn't act on those thoughts. And he said that there were times that he wishes that he was dead, but he does things to distract himself, like play video games. So as I said, I saw him for that initial visit, and it was pretty sporadic in terms of follow-up for a while until I was able to start seeing him at school. As I saw him at school, he never like openly disclosed to me that he was having like suicidal ideation, that he had any thoughts or a plan. I did get calls from the school on a couple of times through the last school year when he had gotten angry, had an emotional outburst in class and said, I wish I'm dead. Or there was one time that he drew like a very graphically like violent picture, enough, that the school was really concerned. So we initially referred him, had mom take him back to the pediatrician for medication evaluation for mood. This was at the initial visit, and mom never kept the appointment, didn't follow up with medication evaluation. I also referred them to home-based visits so that that they could have a provider come into the home and do more of like a family intervention, and they have never kept up with those referrals either. So I have continued to see him at school. So during, his sessions at the Schoolbased Health Center, he was initially pretty irritable and kind of oppositional whenever I saw him. But, over, a month or so, rapport kind of built up. He kind of got used to seeing me, and he was a lot more engaged and cooperative. He did really well when we had a structure. So there would be, we did therapy games. And some of it, he kind of would give me the eye roller he didn't want to do. But if we kind of structured the session so that he kind of got to do something that he enjoyed at the end, then he would kind of go along and put up with the interventions that I was working with him on. So it almost kind of became playful, and he was really receptive to that. And so some of the things that we worked on during his sessions questions were, mindfulness skills, anger management skills. We did things like role plays. And he really did a nice job of like demonstrating that he understood what we were talking about and that he was able to do it. But there wasn't a whole lot of carryover in terms of the behavior that they were noticing at school. Like he was still kind of having a lot of irritability and like anger outbursts at school. And I really didn't get a lot of feedback from mom. Mom only kind of would get involved when the school was concerned and upset. So she might show up and would kind of talk about what was going on. But then I wouldn't hear from her again for a while. So I don't have a whole lot of information on how things are going at home. He's not taking any medicines at this point because mom, kind of failed to follow through. And I had considered referring him to our medical provider at the school-based health center, but I was also kind of concerned about mom following through on medicines. So I wasn't sure about that. So we haven't done, I haven't made that referral since that initial evaluation, at the community health center. In terms of his psychosocial history, the family has really had a lot of stress within the last few years. He is currently living with his maternal grandmother and biological mother. His parents are divorced, but he does see his father regularly. And a lot of times, like, dad will come to the house and visit him there. And then there's conflict between mom and dad when dad comes to visit. He was raised partially by his paternal grandmother up until 2015, but she passed away suddenly. And, that thing that I've been told, like, he was very close to his paternal grandmother, and he does not talk about that at all. Not long after that, mom was in a pretty significant car accident, and then their home was flooded, and they ended up moving in with the maternal grandmother. During that time, the family was still together, mom, dad, and the patient, but mom and dad, like, domestic violence really escalated at home, and they ended up getting divorced. Mom says that patient witnessed a lot of the domestic violence. And as I said, now dad will come over to visit. It doesn't sound like it ever gets to a point of being physical, but there's still, like, a lot of conflict. Dad will kind of, like, storm off and say he's never coming back again. And so patient gets really worried about when he's going to be able to see his dad again. So mom reported that both she and his dad have been diagnosed with bipolar disorder. She also said dad was diagnosed with ADHD. There's a history of anxiety with the maternal grandmother. So my questions with this case, I even though I've seen this kid for a long time, I don't know that I feel like I have a good handle on his diagnosis. I ended up just giving him an unspecified depression, but also have thought about disruptive mood dysregulation disorder, major depressive disorder, adjustment disorder, oppositional defiant disorder. So just kind of wondering, what thoughts are on diagnosis for him. It's kind of hard because even though I've seen him for a long time, I don't feel like I get all the information in terms of, like, what's going on at home. So also wondering about medication evaluation, if we did refer to a medical provider at school where, he would be likely to keep that visit, what kind of recommendations would there be about medicines to start? And then any ideas about assisting him and using the skill that he can do, like he demonstrates in therapy, and having some carryover into, like, his daily life. Any ideas for getting mom more involved?
So I'm going to go ahead and start with the first one, which has to do about diagnosis. And as we were sitting here, Amanda and I were comparing notes to see what we had come up with, and we actually came up with the same diagnosis.
Okay.
We obviously have not seen him before and don't have the length of time, but as I listen to your presentation and I read the information, my impression is major depression.
Okay.
And I base that on loss of interest in things. He's got mood issues. He's got sleep disturbance. He's got overeating. He's got lots of things that go along. I think one of the things that is always tricky when you're looking at child cases is that there's a thought that if kids have up and down moods or they have irritability, which is what Amanda's going to speak to in a little bit, that there's a, quote, mood disorder. And I think that that's why kids get overdiagnosed with mood disorders, because that's what the focus is. But when you look at kids, we see with depressed kids, we see a lot of mood issues. And for them, it oftentimes comes out as anger and irritability and those things. I think his bullying is probably related to the fact that he's been bullied. He's probably, he doesn't probably have the nicest clothes, and it sounds like his hygiene is an issue at times. So the best way, to not have anybody hurt you is exactly what he said to you. I'm going to be the angry kid, so they can't get to me, and they can't be angry, and they can't hurt me. So I think that that's a lot of what his bullying is, and I think that depression. In that, what I would say is that I think there probably, or maybe, and Amanda, I'll get your thoughts too, I think there may be some secondary anxiety with him, and a possibility I'm going to throw in there PTSD. And I put anxiety in there just because I think lots of times when you've got kids who have that kind of presentation, sometimes the overeating will do that. It's an anxiety thing. There's just this constant kind of an attempt to quiet anxiety with food. We do it sometimes ourselves, and so kids do that. So I think that may be what some of his continuous snacking is, rather than eating meals. And my guess is if he's snacking, it's probably carbs, because that's what fills us up, and that's what soothes us. So that's probably what he's doing. And I don't know for certain that his being overweight is related to that. It could be that's the food choices that mom has, or he's eating snacks, or maybe he had a weight problem to begin with. I don't know. But I think that anxiety probably is in there. I mentioned PTSD because I hear trauma all the way through there.
Yeah,
I hear physical abuse. I hear that flood. The paternal grandmother that he was so close to, she died unexpectedly. He doesn't even want to talk about that. He's got his dad there. There's just a continuation of that domestic stuff. And he says in there that he saw most of the fights. Now he's got the fear, is that going to start up again? Or when his dad leaves, says, I'm not coming back, then he's traumatized about the fact that his dad's gone. When he comes, is there going to be another fight and the possibility his dad's going to desert him? So he's got loss, potential from his dad. He's got loss from the grandmother. He's got, to me, when I look at abilities, I don't see it as a disruptive mood dysregulation. I think that it's more, I think I can put it back more easily to something like depression. I could see why you'd think that. I think the unspecified depression, I'm going to go ahead and put it in the category of major depression, because I think that's the criteria for that. So I think that's where you're at with that. Adjustment disorder, I think it's gone on way too long for that. I think we're past adjustment disorder. And the oppositional stuff, I think that's more related back to depression.
Yeah,
I think that
it doesn't sound vindictive. It sounds more like he's responding to his environment. More responds to his environment.
He responded to you. He participated in therapy. He did that with you. But I think his go-to action is anger. Because that's his safe place and that's his safe response. So he's going to probably approach anything that's new with real caution. So he's going to have his guard up and he's going to be angry.
Yeah.
I
think just like my impression based on what they kind of tell me at school, like he does like demonstrate a lot more oppositional behavior at school. And I I don't think that he's really like formed a connection with anyone at school. And I mean, I really feel like that's been the difference in getting him to kind of be engaged, you know, with me, is that we have had that one-on-one time over the course of it, you know, a significant amount of time. And so I think, you know, when that's, I think where the confusion with diagnosis comes in, is because what I hear, you know, I hear from the school. I don't really have a lot of input from mom. And of course, he's not the best historian, being age 9. And he likes to present himself as the tough guy. And so it's hard, you know, hard to kind of get him to articulate any trouble with anxiety. And, you know, he says you know, he's not affected by the things that happen to him, because, you know, he's kind of got that presentation like he's just not going to go there. But yeah, trauma is definitely something that I have really thought about with him. You know, I feel it's a big part of his presentation.
And I think that tough guy persona is more of a defense mechanism that leads back to that anxiety, right? So he's gonna be aggressive before somebody is towards him, and so I think that that's where some of the anxiety presents as well.
But the good news is that, and I know that Amanda's going to speak to this, he has the capacity to engage.
Yeah.
Because do that with you. My guess is if I had to guess, here in this history, he's not real engaged with mom necessarily, or grandma.
No.
So you know, his even understanding about how people engage. I mean, his first memories are of his mom and dad doing, you know, yelling, screaming, hitting, whatever was going on there. So that's his first, you know, exposure to relationships.
Yeah.
And you know, and so this does not come naturally to him. Just to speak to the two other, you know, the mention of ADHD and bipolar, you didn't mention anything about the school, you know, saying he's inattentive or that kind of thing. Before I got to ADHD as a diagnosis, I would want to treat satisfaction as depression and potentially as anxiety, to see what you've got left there before I would traipse anywhere near ADHD. And bipolar is not on my radar. I don't have any idea if that people really have bipolar disorder at all. But that is certainly nothing about this. Now, I know that other people will look at that and say, oh, I think this might be bipolar because he's angry. He's this. Not to me, it doesn't. I don't think it does to Amanda either. I think there's lots of other ways to explain this. That's going to bring me to part 2, of which is medication. What would you prescribe? So my recommendation would be an antidepressant.
Okay.
That's what I would give him. And the two that I start with would either be fluoxetine, which is Prozac, or the escitalopram, which is Lexapro. Those are the 2 medicines. They're approved for depression in kids by the FDA. So you've got, you know, some evidence-based literature from the FDA saying that they're effective and safe. So those would be that I would start with. There's some others that you can drift from there, but I think either one of those would be completely appropriate. If he is really, and the other thing too that goes to depression is his sleep disturbance. You know, he's got early morning awakening, he's got difficulty with sleep. So that again feeds into that. You might, if he is still having some sleep issues, you might prescribe some over-the-counter melatonin for that. You may get benefit, and the sleep may straighten itself out without anything else other than an antidepressant. But if he's still struggling with that in school starting, that's a consideration that you could certainly. I wouldn't get any more than that, and I wouldn't get anywhere near ADHD medicine, and certainly not any medicine that would not be in my differential. But that's where I would start with medicine.
Okay.
Take it away, Amanda.
Yeah, I agree. I agree with the major depressive disorder. I think given his significant losses, loss of energy, hopelessness, eating, I just, you know, as far as mood dysregulation, I really don't see that his temper outbursts are out of context or disproportion to the situation that's given, right? bullied, he's responding and being by bullying others. He's responding in aggression. And I agree with Dr. Goody-Coons as far as, not really understanding or knowing how to interact with the adults. And I think that given his trauma, you're right. He's got trauma across the board. 4 and 6 or 7 on the ACEs, right? And that's pretty high. So given that and the age and the developmental age that this had occurred, he was probably around like 5, right? And so that's the age where he's supposed to feel safe and secure to, de-center from his family and start to explore on his own. And it doesn't sound like his environment was safe to do that, which would lead to transition towards adults later on. And so, he's really just responding to his environment. And that's sad because it does come across as a lot of the behaviors. The unfortunate piece of that, though, is if his aggression and irritability continues without being treated and he doesn't engage, which he is, would be a precursor for a mood, a mood dysregulation or bipolar down the road. But I mean, hopefully, kudos to you because you're doing a fantastic job engaging him. And you said he's not really a great historian or doesn't articulate, but it sounds like you've got him to articulate pretty well. I mean, you're able to identify where his anger is exactly coming from.
Yeah.
What he's angry about is, and I'm actually really surprised that he didn't demonstrate behaviors early on. This is
Yeah. I think my impression is that paternal grandmother was kind of like a stable force in his life and kind of maybe sheltered and protected him. And then, then when he lost her and a whole other number of things happened, like he kind of lost that. He is very open and talking to me about in the moment, current day concerns, like I'm mad at this person at school because they did this. And he will sometimes come in and tell me what he's upset, like what mom's done in the last 24 hours to make him mad. But he doesn't, in terms of history, he doesn't talk about, he just kind of doesn't go there. He minimizes anything that's kind of happened in the past. So he is very receptive to interventions that are targeted to, what's going on right now at this moment in life. But he doesn't, want to open the door to, to any of the things that happened in the past.
Well, and sometimes when you have that dysregulation and irritability, a lot of the times something to open up that barrier might be just having him identify a time in his life outside of this, and maybe when he was younger that he felt that way. Can he remember? Think about the way he was feeling when that aggression occurred, and if he can remember a time in his life where he felt that way before. What that's going to do is help trigger some of his implicit memories. With the type of irritability or mood dysregulation, the brain's a funny thing because behaviors come from those neurological folds that are still developing. And, the top of our brain is the logic piece, and it goes to the bottom, right? And that's the emotional piece. And it's completely under construction in the first 5 years of our lives, which he experienced significant trauma in that time frame. And what happens is that, so arousal occurs from the top down. And so that's your thoughts start. Well, for kids who are younger, they can't cognitively, pull thoughts together. So what it is it's the implicit memory. It's those physical and emotional responses. And then it triggers that emotion response. You literally have to process that emotion before they can provide logic to it. So helping him identify, because he's not going to understand at 5 what's going on in his home when he has a significant loss or when he witnesses domestic violence. But those emotions are going to fire and wire together as an implicit memory. So when he has that feeling again, it's going to take him all the way back to that trauma. And so helping him identify that implicit memory is going to be helpful for him to start processing that. And then it'll help him, help you get there because he's not going there right now. I'm not sure how much time you have available set up in this. There's a lot of barriers when you're doing school-based, I think.
Yeah.
Go ahead. I'm sorry.
I was just going to say, I mean, and that's part of the problem too, is like my time is limited with him. And I like don't want to open a whole bunch of stuff and then like say, all right, we'll go on back to class now, because, you know, when he is irritable and angry and upset, it takes him it takes him a long time to like come back down. And so, so part of it is, that's part of why we have kind of focused on, you know, what's going on right here, right now, today, as opposed to kind of getting into that stuff, because I do kind of have concerns about like going there in the setting that we're in, and especially knowing he's not going to have support when he gets home, probably. You know, there's not really like a safe place for him to go and, you know, some difficult emotions.
Yeah, absolutely. You have very valid concerns, and you know, school-based is very necessary because it's reaching a lot of our kids in the community that aren't able to get the care they need, and you see that especially with this case. However, across those barriers, like parent involvement is one barrier. Logistics is another barrier. I mean, when you're in school-based, it's a hectic environment, and you're probably usually responding to more crisis situations. You know, people because they're having anger outbursts or pieces. And so it's really hard to get there. There are some effective models. There's a cognitive CBITS, cognitive intervention behavioral for trauma in the school. And so, but you know, that speaks to addressing trauma in that, you know, that environment, and how addressing some of those barriers as well. That might be helpful.
Yeah, I just went through the training for Bounce Back, which is like taking CBITS to the elementary level. And so I've been in touch with the school about trying to start something like that at the elementary school, because there are several kids who kind of have a similar presentation. And I think they would benefit, but you know, sometimes just the logistics of getting it all worked out, I mean, it takes some time, but I'm hoping that we'll be able to get that started, maybe if not in the fall, maybe in the spring.
Yeah, and that's another well-identified barrier in school-based is getting the support of administration. So if you have that, you're ahead of the game, you know, in trying to get that across the board. So I think that that's fantastic. You know, do you talk to mom? Have you talked to her at all? Or?
My contact with mom has typically been when the school calls mom and says, you need to do something about this, or something major is going to happen. And so they typically will call me, and they'll call mom, and we'll meet, and mom will agree, I'm going to do home-based services, I'm going to do this, I'm going to do that. And then mom never follows through. And I don't hear from mom again until the next time they're threatening to, you know, put him in a different setting, or, you know, he's going to get suspended. And then I might hear from mom again. But it's always because of some crisis. And she kind of approaches it with like skepticism, like she doesn't really like acknowledge that there is the degree of a problem that there is. My impression of mom is just that she kind of struggles with her own mental health issues, and she's just not really able to get it together.
Yeah. Yeah, you know, I mean, she is bipolar. That's one of the biggest signs, is undermining treatment and medication. And so, but, you know, it sounds like you're always presented as support during very difficult situations. And so she's a little skeptic to begin with when she does.
Yeah. And she doesn't like answer when I call. Like, I don't have the opportunity to like engage with her in a different way. Because she's not receptive. Like I usually don't get a call back, or she doesn't answer the phone, or so I've tried, like I said, I tried to get them to come in through the summer. But I never get a call back from her.
I was going to ask you if you have the capacity to bring her in. So you're going to bring her in.
Yeah, I mean, it would be hard at the elementary school, but at our other school-based clinic, I have the space, the capacity to do that. But yeah, she responds to a crisis, and that's as much as she responds.
Yeah, sometimes, I mean, so I've got very is when I have a difficult time engaging a parent. Sometimes, I mean, motivational interviewing is going to be my recommendation for her with that, but you have to get her there to get that started, right? And that's where you're having some of the barrier. And sometimes, you know, when I have the opportunity to provide support to a parent and really encourage them, I do go over the ACEs, especially if you have a situation like this, where she might be able to identify all of the trauma by seeing it. Sometimes seeing it is a different response. Now, I've had it go really bad too.
Yeah.
I've completely break down because they didn't understand at all the level of trauma that they've endured and their children, right?
Yeah.
So, I mean, I would just schedule extra time if that's something.
Yeah. I kind of, you know, it's been a while since they came in for that initial visit, but what I kind of remember from mom's like response to that was kind of like, yeah, I went through all of the same stuff as a kid. Like I deal with all of the same stuff. So it was like she almost was like lacking in like empathy because she kind of was, all of that was going on with her as well. And so, hard to get her to
See that a lot. It's interesting to talk about them lacking empathy. Where I oftentimes see is with sexual abuse.
Yeah.
I have sexually abused girls, particularly, and the moms say, "Oh, I was sexually abused too." As though it is just something ordinary. You need to get past it. You need to get over it,
Deal with it,
and have no empathy whatsoever for that.
Yeah, that was kind of the impression that I got, was that mom really was like struggling to have much empathy. And, you know, she kind of said, you know, I was suicidal all the time as a teenager. Like I've been through all of this. Like it was kind of like, I hate to hear it, but you know, it's not that big of a deal. Like we all kind of go through this stuff. And so, yeah, it was really hard to find a way to get her connected and motivated and, you know, really wanting to do. So, I mean, she always signs the consent form. She's always willing to have me see him. But in terms of like her, like active involvement, her doing something, like I've really just struggled very, very much with getting that from her.
Yeah. It sounds like it's a big struggle. It doesn't sound like she's gotten a whole lot of her own treatment.
Right.
Is she the primary caregiver, or does her mother care a lot for him?
I would say that grandmother does quite a bit. Like, I think mom is just kind of in and out of the house a lot. So I do think grandmother does, but I also think grandmother I've not ever met grandmother or talked to her, but just based on what the patient says, like, I think she has her own, you know, big emotional reactions to things. And so, it is very much to be like part of that family.
Yeah, so it's definitely intergenerational trauma, and it looks like you're dealing with different levels, and that's, you know, that's a problem within itself, because it's hard to provide support for this guy if he has trauma.
Yeah,
Might be a good avenue to take, you know, and just trying to engage initial support for him so that he can follow through. And especially if you are able to break that barrier and get to some of his trauma and trigger some of those implicit memories, he's going to need that support at home.
Yeah.
But yeah, I mean, you're doing an amazing job engaging. You're doing exactly what you need as far as assessing. You've gone and you've taken different reports. You need multiple reports when you're looking at moods and struggling between, you know, depression and mood dysregulation. I think that one thing that could be helpful, a concrete technique that could be helpful for you in helping him utilize some of these techniques are, you know, life charting or mood charting.
Okay.
That really helps identify patterns of behaviors. And again, sometimes just seeing it written down and expressing it outside, you know, of their mind can be really beneficial. And so kind of forcing him, he's at a tough age, you're going to have to incentivize that. he's at the age where he's probably not going to do it unless there's a reason for him to do it, which is, which again is part of the irritability, because irritability is actually linked to the reward system. And that's why many of the times kids freak out when they don't get what they want when they want it. And that's why rewards help in those situations. And so, helping him with some of that can be really beneficial.
Yeah, I think that's a really good idea. I mean, he's like very playful with me in terms of like, he kind of gives me like, he gives me the attitude, but like there's nothing behind it, if that makes sense. Like he kind of says, oh no, I don't want to do that. But then he just goes along with it. And I always think, because I think he really, like I said, he really struggles even with anyone at school. Like, I don't know that he has a connection, but he really can be such a like pleasant, like engaging kid. And I hate that. I feel like nobody else sees that. They don't, because he is so difficult, like in most settings.
Well, and he's been modeled this level of aggression himself growing up, and that's how he's learned that pattern of interaction. And that's what he's displaying, and it comes out as behaviors and defiance. And some people just get irritated with that themselves.
Yeah. Yeah, I mean, I've seen like how he engages with like other adults at school, and he's difficult. I mean, he doesn't make it easy to get along with the principal or teachers or whatnot. So, I think they would probably be surprised if they could kind of look inside and see what a fun kid he can be when he kind of lets that guard down.
Well, yeah, I'm surprised at the level of articulation that you've gotten from him, and for him to even understand where his aggression is coming from. I mean, most kids who've experienced the trauma that he's experienced, their first response is, I don't know why. I don't know. And sometimes they don't know, but he totally knows. And so it sounds like he's motivated for change, and you're taking advantage of that. And you're really trying to help him. So I think you're doing an amazing job.
Thank you.
Thank you so much, Margie. We appreciate it. I think it was a great discussion for everybody to hear.
I mean, we covered most of the points. We can do it next time if you want, and refer back to the case if you want to do that. I mean, sounds great. Yeah.
We're going to hold the didactic until next time, just because we covered so much of it with this case, thankfully. Yeah. So any other questions, comments, anything you guys want to hear in the future?
You guys hear me?
Yeah.
This is Donald. I just had a quick question for Dr. Gudikinson, the psychologist there. We deal with a lot of, disinterested parents trying to make them interested. It sounds like it's very hard for you, and me and Margie always deal with this. And my question is, the Prozac and the Lexapro, oftentimes we try it for so many weeks, and then they come in and tell us, oh, it's not working, let's just take them off the medicine. And I don't know if that's not working, efficacy isn't working. The parents aren't doing what they're supposed to at home, or really the SSRI isn't working. So I don't know if I'm just pushing the medicine, even though they say it's not working, or is it the parents who are just disinterested and not engaged?
Well, I find it to be a whole variety of things, and Amanda probably has too. So sometimes it's because the parents don't fully understand what it is that the medicine is supposed to do. So sometimes when parents come in and say, the medicine isn't working, I will say something, tell me what you hoped it would change, or tell me what you thought it might do when it would be working. And then I'll get an answer of, well, he'll be picking up his clothes, he won't argue with me, he'll take the dog out when I tell him. I mean, things that no medicine was ever intended to do. So one of the things that I need to do a better job of and remind myself as a clinician is, when I'm prescribing these medicines, I need to describe to them what it is that I'm hoping to achieve by the medicine, so that there's a little better understanding. Now, they may forget it before they come back, but I find that that's really on me to make sure that I have expressed to them what the medicine is really for. It's not a happy pill. It's not a go cut the grass whenever I tell you to pill, that kind of thing. So that's really important. The other thing that I think is helpful, and this is when subject isn't always helpful, and that's when I lots of times will do some of the screening tools where I will have them fill out some of these self-information things, because it takes them down through a series of questions, and that's a little more, it's objective to a point, but it gives me some effective ways to look at the information rather than just saying, well, how do you think you're doing, or how do you think he's doing, because we see that a lot, and that's usually not very helpful, particularly with some parents. So again, I think that education at the front end of it is really important. Sometimes it will be that they're not interested. Sometimes it will be that the parents don't believe in the medicine. They only reluctantly went into it. And that's, again, something kind of at the front when I will say to some, tell me what your concerns are going into the medicine. Tell me if there's anything about the medicine that worries or concerns you. And if they say, well, I've heard bad things, it's always important to say, tell me what you've heard, tell me what your experience is, because that tends to be something on the internet or somebody's relative who had a problem, or maybe they took medicine and it didn't do well for them, who knows. I try to answer those things going into it, because after doing this for a while, I've really found that just trying to say, how you doing, or something like that, doesn't really give me the information all that well.
Yeah, I would agree. I always ask families to give me specific scenarios or situations, like run me through the last time this happened, and we go step by step, helping families to identify and separate the irritability and mood versus non-compliance. So when they like give you the cluster of symptoms, so that you can help them separate to identify, you know, what exactly the medication is going to help and what it's not going to help. And, you know, I do find that a lot of parents are disengaged. Unfortunately, it's a systemic approach, especially when you're working with kids. You know, you need to have the support of the family, and you have to engage, and you have to develop a therapeutic alliance with everyone in the family when you're doing therapy and addressing meds. And I think that you know, what I've noticed is I have to take my time. I have to slow myself down, and sometimes I have to do like, it's the kid's session, but I end up doing therapy with the parent for 2 sessions until they're engaged with me, right? And so that may be like we were talking about when she's sitting there saying, well, you know, I was abused. This happened to me. And so kind of just exploring that and not opening the full can of worms, but just empathizing and supporting and just acknowledging and reflecting. Staying reflective will help them feel more comfortable with you. And so, you know, usually after 2 or 3 sessions, but, you know, that's if they come. And so, and many of the times it's their own anxiety too that prevents, I mean, there's times where I've had sessions with them and they're going to the doctor right after me, and sometimes once parents have engaged with me, I have to prepare them to tell the doctor truly how they feel about things because of their own anxiety about it, and for many different reasons. And, you know, and usually it's their own trauma and experiences.
And sometimes I find that there's this thing, and you probably have as well, there's this thing where parents are hesitant because they see physicians as quote authority figures or whatever it is, and they're hesitant to really say anything that they think would make us unhappy or disagree. So if it's, how do you think, oh, it's doing better. Do you feel like he's sleeping better? Yes. So there's kind of like, I don't even know what to call it, but this tendency to just kind of go along with whatever it is that we're saying, to agree with us or please us, but there is an anxiety, intimidation factor sometimes that will go along with that. So yeah, so I think that's, you know, trying to make them comfortable with what's going on, having them, you know, have a say-so, having an, you know, informed control over what's going on, I think is really important.
Yeah, absolutely. And fact of the matter is we live in rural Appalachia, and so there's a huge stress factor, as well as many of our parents that we work with are in recovery. And so anything that comes to medication, they're already feeling judged, and so a lot of the times they shut down as well.
A lot of time I just tell them, like Dr. Goody says, like the medicine can only do certain things, and we need to do therapy for the other parts. But then that's when they say, I don't believe in that part of the treatment. So that's where the other resistance comes in. But I always try to.
Ultimately, part of what we have to do is park our doctor ego at the door, because people, sometimes I'm going to recommend that that child that is hanging off the ceiling needs some ADHD medicine, and they're not having it. So my job is to educate as best I can, make the recommendation as best I can, but it's not a personal attack on me if these people walk out and they don't have an Adderall prescription with them. So that's my job. You know, my job is to do the best that I can based upon that. But, you know, I'm not going to be mad at them. I'm not going to hammer it into them that they've got to do that. So part of that is our attitude too, and making sure that we're not, you know, coming across as, well, I'm the boss and I know better than you do.
Try not to, like, the paternalistic, like at women's here, they always seem to like up here we had HIV and Hep C screening, and they told me, because everybody's resistant to screen for that, they want us to do the opt-out approach, but I feel bad to force everybody to do something and have them opt out. I'd rather have them decide with me and
right.
Yeah.
treatment with me.
No, I agree.
We have one more question that I want to get to. So Jennifer chatted in a question. I'm having trouble hearing you, Jen. But so let's see. With the family history of the patient you discussed, with the family history of bipolar, as he gets older, would there be anything you would monitor for? I don't think either of the medications discussed were risky for someone with bipolar, but venlafaxine is risky for bipolar. Is that true?
Well, I think that if you had a true concern about bipolar disorder, there's certainly less, I think, evidence now that you're going to cause someone to quote unquote flip, okay, from bipolar. What I would be watching for myself is I'm giving them a medicine for depression, and either for a while they do better, and then they start to be like on this increase in mood issue. I've seen that happen, or I've seen people that I prescribed it to, and the first thing I'm seeing or hearing about is a worsening in their mood lability or a worsening in their anger and that kind of thing. That to me is a flag that I need to stop and think and look at what I'm doing. So what I would say is what you're monitoring for is the chances of you necessarily seeing frank mania is probably pretty low. But I think that if you start to see something that's looking worse in a mood variety, I'd be starting to pay close attention to that. That's what I would be doing. So,
great. Thank you. Okay, guys, we're kind of at the end. So thank you all for joining and attending. If you guys have any other questions that come up, happy to forward those along and get you guys back some answers. And our next session is in 2 weeks on the 21st. So I'll make sure to send out those reminders and everything. Thanks. See you later.
Thank you.